All righty. It's showtime. Okay. Hello, everyone. Welcome to CPC or our Clinical Pathologic Conference. Special shout out to all the applicants who are Zooming in. We are so happy that you are here with us today on your interview journey. For those of you who don't know what CPC is, this is a long-standing tradition at WashU where we have our expert diagnosticians come in and walk us through a case so that hopefully we all get a little bit smarter. So with that, our expert today is Dr. Dennis Chang. He is quite the worldly man, as you will learn. He's jumped all over, but has done med school in Chicago, and then he did residency at NYU. And we are so lucky to have him here today at WashU, where he's an associate professor in the Division of Hospital Medicine. And he does a lot of great work with interprofessional education and medical student education with their clinical immersion. And now I will hand it off to Dr. Chang. Into our case, we have an 18-year-old female with a past medical history of eczema, presenting with several days of malaise and fevers. And now I will turn it over to Dr. Chang to walk us through kind of his initial thoughts.
All right. So when they first sent this to me, I was like, wow, that is an extremely broad differential diagnosis for a young woman with fever. So I started sort of thinking about how I really sort of break down fever. And I think for me, it's really like three sort of main points that I'd want to know from the history, which is sort of time course is probably the most important one, right? I think the differential changes a lot between someone who has a fever over a few days versus someone who's having fever over a week or 2 weeks or even over 3 weeks. And then the other things I always think about when someone has a fever is like, what's the environment? Where are they coming from? What kind of exposures has they had? So that's what we talk about, the travel history, but also just sort of their occupations and what they do. And then the third one, which is always really important to me, is sort of like the immune status, right? I think that changes your differential quite a bit depending on what their immune status is. Somebody getting chemotherapy or someone with HIV or AIDS, that's going to be a very, very different differential when you think about fever. Now, the other thing that they gave, which I'm always like a little interesting, is like, if you read a lot of these like CPC things, they'll say malaise. And what does really malaise mean? And that's like, I had to look this up too, but like malaise is like the French word for like discomfort, basically. It's two words that mean discomfort. So it's pretty broad. So it's unclear whether that will really, help you at all. And if you look at any sort of like ID disease in the book, malaise is probably in there every time, right? So it doesn't necessarily help you think about it. So we can go to the next slide. So I wanted to get the audience a little involved here. So, when you think about fever, I think the other thing you also have to think about is like sort of things that are more commonplace, right? So how do you all break down fever? How do you sort of organize it in your heads? I'd love to hear from the audience. Who has a way that they think about fever? Translate to inflammation? Talk more about that.
So I guess broadening it the more as a can be a sign of inflammation.
Sure.
My head to that, and then different folks have different approaches to how they kind of model for inflammation. In my case, I think of infection going to be autoimmune drugs and that.
Right. So what Francis is talking about is kind of like you can have fevers for non-inflammatory reasons, right? You think about, heat stroke, stuff like that, right? So the first thing you sort of want to establish is whether it's inflammatory. Most of the time it is, right? That's why we don't usually go down this whole inflammatory track. But okay, let's say you assume it's inflammation. How do you break it down? How do you decide? How do you go through your head and make sure that you're not missing something? Who has a mnemonic? Anybody have a mnemonic they use? I'm sure anyone who's been on my team, I've said this before, is like, for me, mnemonics are really hard because I don't have a great memory. So I have to remember the mnemonic and then what the mnemonic means. That's a lot. That's a lot for me, right? So I have to think about it in a little, so what's other ways people do it? Mnemonics, what else? Anybody brave enough?
bucket. One thing I would be looking for first is, do you have any localizing symptoms that?
Okay.
Any localizing.
Good.
Back and forth.
Yeah, great. So for me, the way I just think about like organ systems, right? This isn't exactly how I think about it, but sort of thinking about organ systems. Some ways I've heard other people say it is like I just think about what consult service I could consult, right? Which often is broken down by a body system. So however way you do it, but I think, with an 18-year-old with a fever and eczema, you think about all the common things, right? So you think about, female reproductive systems, urinary system, respiratory system, digestive system. You think about endocrine stuff, hyperthyroid. You think about meningitis or encephalitis, skeletal muscular. You think about cellulitis, osteomyelitis, septic arthritis, circulatory stuff, right? You can think about carditis, endocarditis, myositis. So it's very, very broad. I don't think we have time to necessarily go through all of them. But I think the biggest thing you have to think about is what is most common. So for an 18-year-old female, what would be most common? That's just the most common thing you would think about. Say it again. STDs, okay. So STDs, UTIs, right? Absolutely, those are things that are sort of like top of list, right? What else? UTI, pyelo, what else? Say it again. Other viral infections. Yeah, absolutely, right? So URIs, right? That's a really common thing we see. Whatever you want to call what kind of viruses, about COVID, flu, depending on what season it is. So that might be another question, is kind of like, what time of year is it that this is happening? What else? How about the eczema? So let's bring in the eczema. Does the eczema change anything for you in terms of trying to narrow down this very large differential for a body system? Okay. What kind of complications? Yep. Sure. Yeah, right. So super infection. So she could have a cellulitis or a much deeper sort of soft tissue infection, depending on how bad her eczema is and where it is. Right. So that might sort of lead you down that path. So that's kind of what my general thoughts were. And I did want to just add a few other things to sort of add to what we were talking about, right? So when we talk about the environment, it's also important to sort of think about what are the environmental factors. So we're going to ask these questions, but what questions are we really going to ask about their environment? And you can look up all of this stuff. There are laundry lists of things you can get from working on a farm, laundry lists of things you can get in your household, the bugs, things like that. What I listed here is just like the most common ones. And I think that's easier to sort of break down in your head a little bit, is thinking about like, hey, are there household things that are particularly things I would think about? Are there, if they live on a farm, that kind of stuff is sort of a big one, especially when we talk about Missouri and where we live. And then obviously the bugs, right? West Nile, Lyme, rickettsial. Rickettsial is a really common thing in Missouri. And then travel, right? You think about bacterial things. So this slide got a little messed up, but bacterial, you think about typhoid, leptospirosis, rickettsia, viral, dengue, Zika, and chikungunya, and then obviously parasites and malaria. So those are sort of the things you think about, the most common things that should come to mind when somebody comes in with fever. And then the next slide, I just try to highlight some of the things that are more chronic. So we talked about the time course being so important. A lot of these exposures, things like that, it actually comes down to time course, right? Most of the other ones are acute, whereas Q fever, cryptococci, histo, TB, those kinds of things are a lot more like long-term things that you'll see after several weeks after exposure. So just important to sort of think about those things and sort of the temporal variety of all of this. And then Francis sort of mentioned this too, right? Is if you think about infection or fever, infection is sort of the number one thing. But if this is something that's been going on for a lot longer, then you start bringing in these ideas of autoimmune, drug, endocrine, and malignancy, because those are going to be fevers that have been going on for a lot longer. They're not going to be so much acute. Most people don't seek care after like 1 or 2 fevers, right? Unless they're really feeling sick. So, all right.
All right. Excellent work. Thank you so much for giving us that framework as we go into the next aliquot. I'm going to give you the HPI, the background information, the ROS, and then we'll pause and hear your
Sounds
thoughts.
good.
Okay. So our patient, she's coming in with 4 days of fever where she actually has gotten temperatures at home up to 102 degrees Fahrenheit. She's been saying she's just feeling really crummy. She's just weak all over. She's lethargic. She's sleeping more. And as any 18-year-old knows, mom, of course, is in the room. And she's saying, maybe it's been going on for a little bit longer. She's been lethargic and kind of sleepy for the last couple of weeks. And it's just gotten progressively worse the last 4 days. She hasn't been eating very well. She's nauseous. And she does cite one episode of loose stool. She denies any blood. For medical history, she's pretty healthy, 18-year-old. She does have maybe this questionable history of nummular eczema. This is the winter time. And a couple of months ago, she had this itchy rash all over her lower extremities, over her forearms, behind her ear. She had a derm appointment, but by the time she got there, the rash had actually gone away. She also has a history of heavy menses. In terms of surgical history, there's nothing, no allergies, no medications. For family history, she's got an aunt with lupus on dad's side. Social history, she lives at home in St. Louis with her family. She just graduated high school. She's not working currently, and she denies any tobacco use. She says she maybe drinks 1 or 2 beers with friends, sneaking it maybe once a month. And then she denies any drugs, no IV drugs. She says she's smoked marijuana once. And for our review systems, a lot of the same things that we got in our HPI, fevers, fatigue. She's got diarrhea, nausea, but then maybe some additional things when we talk to her. Actually, in the ED, she's having some epistaxis. And then she wears her hair in pretty tight braids and bleaches them. So there's maybe some hair thinning kind of by her hairline. And then she's citing these arthralgias and myalgias. And then there's this kind of residual hyperpigmentation from this resolved rash. All right. I would love to hear your thoughts. I'm happy to go back to any of the slides, or if you have questions, I can answer them.
Before so travel.
So no travel.
And sounds like she lives in St. Louis.
She lives in St. Louis.
Necessarily
urban setting. No exposure to farm animals, no cats, dogs in the house, no birds, you mentioned. There is a hamster in the house. It's sister's. She doesn't like the hamster, doesn't really interact with said hamster. She has been sexually active twice in her life. I don't have much history about partners or last time that she was sexually active. Is there anything else you want to know?
And no real travel like outside of the city.
No travel outside of St. Louis.
Okay. So what sticks out to you? What are some things in the history that maybe you have more questions about? Or that might lead you in a different direction? What about the eczema? How do we feel about the eczema? Anyone very concerned about this eczema?
I feel like the rate of eczema is growing in a lot.
Yeah.
I try not to say that whatever she experienced was absolutely eczema.
Yeah.
Leave it a little bit, be something else.
I totally agree. I think that what is being described, it's unclear if it's really eczema. I'd almost like, in my mind, it's sort of like, I'm sort of leaving that as like something that's just being in the history, because what she's describing is a rash that isn't quite eczema, so maybe it was something else. And so to sort of take that off as something that could sort of lead you down the wrong direction. So that I agree. That was sort of my point about bringing up the eczema, is that I'm not sure if we should sort of see that as a diagnosis at this point. What about the epistaxis? Does that make you think of anything? What's the most common cause of epistaxis? Trauma, yeah, nose picking, right? So is that something or not? So what I'm trying to go through down is like, what are the things that are in that history that are things we should be sort of adding to the laundry list of things that she's starting to have? Or what are the things that we can sort of put away as maybe something else? So what's something concerning that could cause epistaxis? What's that? Like a coagulopathy, right? So, usually if we think about infections and inflammatory things, we think about platelets being really high, right? So if she's having epistaxis or her platelets low, is that leading towards things like you think about, hematologic malignancies, right? We saw that on the list of sort of subacute. Now, the fever is 4 days, right? So that's pretty acute, right? It's hard to imagine that somebody who was, having a lymphoma or something like that would have this would be the first time they were ever had a fever, right? This would seem to be something that they've been having over and over. Now, leukemia can, right? We do see people who are pretty healthy and they suddenly just have epistaxis and fevers, and that's sort of something you can think about. So that's, I agree, is sort of the coagulopathy part of it. And also, if it's winter and, epistaxis is a fairly common thing. I think the other things that are sort of making me wonder about, our differential in terms of infections are these arthralgias, myalgias, right? These are really, really common things that we see in patients with infections or viral infections or any sort of like tick-borne or mosquito things. And obviously she doesn't travel, so it seems less likely, but it still can happen. You also start thinking about like autoimmune diseases, which was part of our differential, right? Is this sort of our first presentation of some sort of autoimmune disease? You think about usually arthralgias, where you think about lupus or, rheumatoid arthritis, but then the myalgia part does make you think more viral, right? Because there's just sort of these muscle aches. Is this really a dermatomyositis or myositis seems less likely. So just thinking about what our original differential was, this isn't giving you a ton of ways to sort of diagnose anything in particular. Maybe the epistaxis is leaning you towards leukemia. Maybe the arthralgias, myalgias leaning you towards a viral or autoimmune disease. But nothing here is particularly. Now, the only other interesting one is the hair thinning, right? And so that is such a hard thing to sort of ask somebody. It's like, what do you mean by hair thinning? So what would be the thing you think of right off the top of your head with hair thinning from our differential? Yeah, yeah. So it's like, right, it was like sort of pulling, right? So is it really something that's like endocrine oriented or some sort of, nutritional deficiency, but it hasn't really given us any of that flavor. But yeah, it's a little bit of one of those, is it a red herring or is it really something that is part of the differential? So those are sort of my thoughts. Any other thoughts? Any other diagnoses people want to throw in there that I am forgetting? Because I will say that differential diagnosis, cognitive thinking, all this stuff, it's a team sport for sure. So any other thoughts people have? Okay.
All right. So for the next section, I'm going to give you the physical exam and our initial labs, and
Okay.
then we'll pause. All right. So when she comes in, I guess pertinent positives is she truly is febrile. She's a temperature of 38.5 and she's tachycardic in the 120s, otherwise hemodynamically stable. And then she does have these hyperpigmented spots on her legs. I don't have pictures of her arms, but it looks similar. There's no erythema, no open wound discharge, and they're flat. In terms of like pertinent negatives, otherwise, everything's pretty normal. Cardiovascular exam, there's no extra sounds. She's clear on her lung exam. And then her GI system, there's no organomegaly, soft and non-tender. There's no effusions on her joints. She's euvolemic, no edema. And then for our initial labs, we have a creatinine that's elevated from our baseline at 1.1. BUN's also high at 31. Sodium's a little low at 128. Calcium is 7.1. We have a low albumin at 2.7, and then an AST of 79. For our CBC, she's anemic at 9.2. We don't really know a baseline. Her platelets are low at 62, and she's got an MCV of 71.9. Normal diff, and then as a bonus, you get your endo because it was on your differential, and her TSH was normal. All right, we're going to pause.
Yeah.
And I would love to hear your thoughts. What is most striking, I guess, about the findings we have?
I think the striking thing is like, in the beginning we started talking about inflammation, right? So the markers that make you think inflammatory, right, are the albumin being low, right? Usually we would expect a platelet being high, but that's actually low, and you have a hemoglobin that's low as well. So I think the hemoglobin and the platelets together are probably the most striking thing to me, because now you sort of have two cell lines that are down, right? And that does really make you wonder, is this a bone marrow issue that's causing you to not be able to making this, or is this some sort of consumptive issue going on? So, you think about, is there some sort of hemolysis or splenomegaly or things like that? Didn't look like that was on exam, but that doesn't necessarily mean anything. Usually the spleen has to be pretty large for you to actually palpate it, so it doesn't mean that it's not large. But then if you think about consumption, then you look back at these other labs and you don't see a bili that's raised, right? So it does make it seems less likely that there's a hemolysis. Now, she does have heavy menses too, which that's sort of, is the anemia from heavy menses or is it from something going on? But the platelets being down would not be from heavy menses. That would be significantly different cause of it. I think what's also interesting is that the sodium is low. And so that brings into the play a whole different differential in terms of what her sodium was. So maybe a couple of questions. Did she say she's been eating and drinking normally prior to the fevers?
The last week or so, she's had decreased intake for sure.
Okay. Last week or so.
Yeah.
Okay. Because then we can sort of get into the differential for sodium, right? So as you think about these cases, you do want to sort of explain each particular abnormality. So I think right off the bat, looking at the CBC, you start thinking hematologic things, right? Because you do have these two cell lines down. Then you start looking at the sodium and the creatinine and the BUN. Is that all consistent with dehydration, right? Which you can see that with hyponatremia. But then it starts thinking about, well, if you think she looks euvolemic on exam, then you're starting to go down a different path, right? Is this SIDH? Is this a thyroid issue, although the thyroid looks normal? Is there adrenal insufficiency? Is there other causes, right? So sodium SIDH is just a syndrome, remember that? And so what are the causes? What's causing the SIDH, right? Is also an issue. And then the AST being a little elevated, right? So that's an interesting one too, right? Because we do see in infections, she's got a temperature as well as tachycardia. So are we seeing a more systemic infection going on, right? You've got inflammation in the liver, you've got, this sort of low sodium, you've got low platelets, hemoglobin. This could also be like just an overwhelming systemic infection. Could it be viral? Could it be bacterial? Any number of things. So my differential right now, I would be thinking still infection, right? You've got a fever and tachycardia. You've got a lot of stuff here sort of putting you down this line of some sort of overwhelming infection. We don't have a particular cause. There's nothing on exam that's sort of pinpointing a particular area. So right now what we have is a patient who has signs of like systemic infection. Does she possibly have a bone marrow issue? Does she possibly have some other malignancy or something that's causing sort of worsening of all of this? So that's sort of putting it all together. But yeah, there's definitely a lot here, but I don't think it's necessarily pinpointing me to anything in particular. Any thoughts from the crowd, from all these brain power here that I'm missing? Okay.
Is this a lupus flare? So the patient has a family history of lupus, the patient has any symptoms that have been going on, I guess, for a while, like losing hair, arthralgia, arthritis, with fever, has thrombocytopenia, thrombocytopenia, lupus flare?
Could be. I agree with that line of reasoning, right? There could be a lupus. She's never had a diagnosis, so maybe this rash in the past was sort of an initial cause of lupus, initial sort of flare of it. Like you said, she does have an aunt with it. So yeah, absolutely. It's some sort of inflammatory issue, right? So probably you're right. So it could be infectious or it could be autoimmune too, right? So she certainly has what numbers? She's got the platelets, the hemoglobin, right? All of this stuff. So could still be something autoimmune. She's young, so it fits that as well. So I think those two are probably still high up on the list.
I guess I'd also ask, what do you make of the hypoalbuminemia? I guess
Yeah.
the protein's normal, but if you look at it, I guess there's technically a gap.
Right. That's good. I like that. So what do we think about with a gap? So obviously, right, she's pointing me towards multiple myeloma, right? So you think about SPEP, UPEPs for her. Could she have a multiple myeloma? Absolutely, right? All this could fit that sort of some sort of bone marrow issue, leukemia, multiple myeloma. So yes.
All right. And then we've learned a lot since our first chief complaint of fevers. Would you just summarize for us, like, how are you representing this problem now that we've learned some new information?
So I would sort of represent this as this is an 18-year-old who's coming in with like a fever, pretty high fevers, showing signs of like inflammation. And is that inflammation from an autoimmune or a infectious picture, or is it from some sort of malignancy, right? You think about that initial diagnosis of infection, malignancy, autoimmune, drugs. It's probably not drugs. She's not on anything, sounds like, unless
No
we have
drugs.
gotten to that
Mm-mm.
history. And so I would say it's probably still on that infectious malignancy, autoimmune type of diagnosis.
Love it. And I guess backing off of that, can you tell us, what do you want?
Yeah. So here, obviously, I think number one, you always have to rule out some sort of infection, right? I think that that's going to be the thing that will possibly cause her demise very, very quickly. So you do want to do the full infectious workup. So you do want to get a UA, urine culture, blood cultures. You want to get a chest X-ray. Well, actually, she doesn't have a cough, so you could consider not doing it, but you probably need to with a temperature like that. You probably want to get a viral panel, right? Do all the usual sort of infectious workup. And then I think definitely you could think about sending like an ANA, or if you're sending, you could send like complements to see if this is truly like some sort of flare. And then I would definitely get a UPEP and an SPEP to sort of rule out that. I think you can also sort of do sort of like minor workups, right? So like if you looked at that hemoglobin, right, it doesn't look like hemolysis, but you probably do want to get an iron panel to sort of see, is this really from menses or is this really something hemolytic, which doesn't sound like? You probably do want to get a smear for sure with the platelets and the hemoglobin. You'd want to take a look at that smear. And then you can do like the sort of sodium workup, right? You can get a urine osmolality, see what that is, get a urine sodium. And then you obviously got a TSH, but you can also get like an AN cortisol or something to work that up. I don't know if I necessarily go down the line of like working up the increased AST with like hepatitis, but I think with the platelets, I would still get a hepatitis panel and just ensure that she doesn't have some sort of hepatitis virus that's causing all of this. And then I'm trying to think the other abnormalities I saw in there. I think that's it. Yeah.
All right. I think that's an excellent start. So I'm gonna give you some of those things that you requested. So for our preliminary infectious evaluation, you had mentioned immunocompetent status being really important. So HIV negative, RVP was negative, blood cultures, at least or preliminarily, no growth to date. We did get a hepatitis panel, which was negative, and we got a chest X-ray as well, which showed a granuloma and then some trace bilateral pleural effusions. You had mentioned a lot of infectious workup in your framework. I'm just wondering, like, what are you preferentially getting? Are you ordering all of those things given her exposure history? What are your thoughts?
I probably wouldn't go down that line right now. I mean, this would be the sort of initial part. She's not immunocompromised. She doesn't have a virus. A lot of the sort of more common infectious workup is negative at this point. She doesn't have any exposure, so I wouldn't be going down this whole like histocoxy, crypto, you know, dengue, all of that stuff. I probably wouldn't necessarily pull the trigger on all of that just yet. Trying to think if there's any other systems we're missing, right? So we did pulmonary, we did sort of blood cultures. She's not immunocompetent. She's immunocompetent. This is acute hepatitis. The only thing right now is sort of these trace bilateral perfusions and calcified granuloma, which is interesting, which does make you sort of think about what sort of pulmonary issues she could have. Doesn't look like she has a classic pneumonia. The calcified granuloma tells you that it's something old, right? So if it is something old, there are some sort of fungal things that do give you old, like, things like cocci and histo always give you something. They usually have some scarring that stays there. So is that possible? I don't know. I'm not sure if I'd necessarily pull it just based
How
off
about I'll
that.
give you for free the imaging, which they got in the
Okay.
ED. So we got a CT abdomen pelvis, which showed some possible mild proctitis colitis, and then a CT chest that showed a lot of effusions. So small pericardial effusion, bilateral pleural effusions. There's maybe some local focal inflammation and some enlarged axillary nodes. Do you make anything of this imaging? And
Yeah.
I guess to piggyback off of that, this patient's febrile, she's tachycardic, we have proctitis, colitis. Like, what kind of management things are you doing in the ED
Yeah.
for her?
Yeah. So I think let's just take what we know, right? Fevers, tachycardia, she's got some sort of proctitis, colitis. I think you start some antibiotics, right? Usually the classic for colitis or proctitis, you think about like ciproflagyl, right? That's sort of the most common ones that we start. I think that's fine. If you wanted to broaden out, you could, if you want to do something, you do ceftriaxone, flagyl, some sort of GI bug type of coverage. Now, the CT chest and all of this is really interesting because what we see is basically some sort of systemic inflammation, right? You've got effusions all over her body. She's got sort of local inflammation, axillary lymph nodes. So this could still be along the autoimmune thing, right? We do see that. It does make me think of other sort of like indolent infections like cocci, histo, or that type of thing. So this might make me pull and try to get some of those histologies like a histoplasma urine antigen or cocci antigens. It might at least do that sort of initial screening based off that type of imaging.
Excellent. And you had wanted some urine studies as well. So we've got a UA, creatinine positive. We've got a lot of protein, a lot of blood, white blood cells, RBCs. What studies are you getting after? And you mentioned, it's a teamwork sport. Are you calling anyone? And what labs are you getting before you call them?
So this obviously really does make you think more autoimmune, some sort of vasculitis, right? With this much protein and blood and white cells. So I definitely would get like a urine creatinine ratio, sort of try to decide how much it is. If you start thinking about protein in blood, you start thinking about nephrotic and nephritic syndrome. So, you're going to get like lipid panels, and then probably you definitely want to spin this down and really see what you're seeing there. Now, the specific gravity is pretty high, so she's probably dehydrated, which might explain the creatinine and the low sodium as well. So obviously you give her some fluids, but once you get that protein creatinine, you certainly would want to call nephrology so they can spin it down and really take a look at this. It does really make you think about rheumatologic stuff when you start seeing some sort of inflammatory process with like a kidney issue. There are obviously some other infectious things that can cause sort of a nephritic syndrome, right? So you think about like endocarditis, things like that can give you sort of protein in blood as well as fevers and infections. So trying to think if there's any sort of other infectious things that could give you renal involvement. I do know some things sort of later on in the course of infections can give you that, but all right. So
you got your wish. Protein to creatinine ratio, more than 7 grams. Your 24-hour protein is 2.6,
Wow.
but maybe underestimated given that 24-hour creatinine. We do spin the urine. There's RBC cast, there's hyaline cast, and then we get the SPEP, UPEP, free light chains. There's no paraprotein detected. Kappa and lambda are a little elevated, but there's actually the ratio is normal. And CK was fine.
Okay.
So you're talking to your nephrology colleagues. Is there any other thing that you would consider potentially?
I mean, would love to see any of those like rheumatologic panels.
Yeah.
At this point, I mean, I think I think you'd have to see if they can biopsy the kidney and see what's going on there, because this is definitely nephrotic range proteinuria. Love to see lipid panel. She's got a low albumin already, so definitely would want to see that.
And you mentioned you wanted an echo maybe to look for veggies. There are none. There's just that small pericardial fusion. EKG was fine. And then you mentioned an anemia workup. Ferritin's high. The other things are low. Retics are low. Does this really add much to what you've already mentioned?
I mean, the ferritin being high doesn't, right? That's all just inflammatory stuff. You do have low iron. And then the retics are low. So, I mean, I think what it does tell you is the marrow is not functioning normally, and it's not utilizing the iron as well. So it does make you wonder what's going on in the marrow. So it still could be consistent with an autoimmune type of disease. Could it be something like hematologic that's also causing the rest of it? It's hard to put that together. So it does really push you towards some sort of autoimmune issue.
Breaking news. She gets a lot sicker. Hypotensive. She's febrile to 103. She codes. Thankfully, we obtained ROSC in 4 minutes after 2 rounds of ACLS. Thankfully, a resident has a butterfly in the room, and she's got a giant pericardial effusion causing tamponade. So she's escalated to the ICU, intubated, but she gets a lot hemodynamically better after we put a drain in. I don't expect that you're an expert at, pericardial fluid studies, but I'll say that it was serous. And there's pretty high protein.
Yeah.
The protein's been downtrending, so it's now 4.7 in the serum, and the protein in the fluid is 3.4. We get cultures are negative. We get cytology kind of going to that malignancy picture possibly, and those are negative as well. As you can imagine, we got a whole host of labs, but I'll point out some specific things. You wanted the smear. We don't see any schistocytes, blasts, but we do see some spherocytes. And then kind of going to that hemolysis picture, we get a low haptoglobin. LDH gets pretty high. We get DAT, which is positive, and then ferritin is 20K. What are your thoughts on a ferritin that high?
Boy, so ferritin's that high, you really start thinking about like HLH, right? That type of syndrome. So that could be it. There's very little that causes a ferritin that high. I'm trying to think if there's any other particular ones.
I think the team was thinking the exact same thing.
That's the only thing that gives you 20,000.
And because she got a lot thicker, they actually did end up throwing a lot of those other infectious studies that they maybe held off at in the beginning, but then she got really sick. So here are some of the things you had earlier requested. We got the tick-borne illnesses, which are all negative. We got the endemic mycoses. Those are negative. The IgG is positive for parvo, CMV, and EBV, but the IgM is negative. I don't know if you have any particular thoughts on that before we move on.
No, I mean, these are all negative. The CMV, EBV, parvovirus probably exposed at some point in her life, not necessarily.
And then I know we've all been waiting for the meat. We got a highest ESR and a high NA, but ANCA's negative. What other studies would you want rheumatologically? I know you said this is a strength of yours.
This is definitely not a strength of mine. Would love to see the C3, C4, right? That's obviously really helpful. You can get all the follow-up, the RF and the, all the antibody things that you can send. I'd always have to look them up. But I mean, I think this tells you with all this that this is some sort of rheumatologic issue. Could it be lupus? It would seem to make the most sense given how systemic this is. But yeah, I'd probably definitely get an RF and all the other stuff that we usually send, anti-smooth.
Whole host of red.
To say all this stuff. I assume
lots of red. What do you make of that?
So what's interesting is they're all positive, right? I think, the more specialized ones, the GBMs, I don't think we are necessarily down that line. The anti-Joe SCL70, that's not surprising. It's negative. That's more of it's spinal stuff. So I think what's interesting, the C3, C4 is low, right? Which is really very indicative of a flare. She's lupus anticoagulant positive, which is not surprising. I think what's good here is obviously, you think about antiphospholipid syndrome. She just has this one, she doesn't have any clots, at least at this point that we know of. But this is very, very positive for a lupus.
Yes, you seem pretty positive. So I guess my question is, do you still get the biopsy?
Good question. I think the answer is yes, and I'll give you a couple of reasons why. Is because I think you need to know what type of kidney disease it is that's going on. Lupus can give you all kinds of different types. How you manage that's going to be different based off what you see on the pathology. The reason I had a little bit of pause and I was just thinking it through is that the platelets are low, right? I don't think it's low enough to like say that's that contraindication. When you do renal biopsies, this data does show about 20% of the time they have some sort of bleed. Doesn't mean it's significant. There's usually a very small percentage who have a very significant life-threatening bleed, but it still is a really high concern for people. So the answer is there's really no contraindication to do it. And I think it gives you a lot of valuable data. So I think definitely would want a renal biopsy.
Well, we do ultimately get it. And so I invite Kyle Goodman, a resident in Path here, to come give us the pathology results.
Hey, y'all. Thanks for having me. Oh, nice. Okay. Okay. So it's always interesting to see exactly where we are in the clinical course when pathology comes in, but it seems like we already have a good idea about maybe what's going on. So let's seal the deal. So real briefly, just so that we're all on the same page, medical kidney biopsy, they're needle biopsies. So we'll get these little pieces of tissue that come to the lab. In this case, our esteemed pathology assistants will actually look at these cores under a dissecting microscope and actually cut it up and separate out. That's to ensure that we get to evaluate these three important compartments, the glomeruli, the tubulointerstitium, and the vasculature by both light, immunofluorescent, and electron microscopy. So real briefly, I wish we had a big screen like this in pathology, but just some normal as a reminder, this is a glomerulus. It's composed of this large tuft that's composed of a bunch of endothelial little capillaries here that contain fenestrated endothelium surrounded by a basement membrane. And then outside of that is the visceral epithelial cells, podocytes. These are all held together by this delicate mesangial network. And as you can see in between these capillary loops, there's maybe one little cell in between them, and then this delicate pink material. Just keep that in mind as we look at the pathology in a moment. And then that's all surrounded by the Bowman's capsule. The tubulointerstitium shown here is we're still kind of in the cortex, which is where the glomeruli are located. These larger tubules that have the more pink cytoplasm and the frilly brush border, that's the proximal tubules. And then these over here that have the more cuboidal cells are the distal tubules. There's some important things we look for in the tubulointerstitium. And of course, we also look at the larger vessels. So the kidney is a very vascular organ, and there's this large branching network of vessels that go into and out of the glomeruli, and there's certain things we look for there. Okay, so let's take a look at this patient's biopsy. Shown first is a H&E image of a representative glomerulus from her biopsy. And there's an important key finding seen here. So while we see a lot of these capillary loops that are open, you'll notice that there's a bunch of material in between the capillary loops. So instead of just being like one little cell in between them, there's 1, 2, 3, 4, 5, 6, 7, and then also an expansion of the mesangial matrix. So in this case, we have mesangial hypercellularity and a mesangial expansion, but we still have the capillary loops present. In addition, there were a few glomeruli that, in addition to having an expansion of the mesangium, there's collapse of the capillaries. This is sclerosis. But you also note that the entire glomerulus is not affected. There's areas where you still have the delicate capillary loops and mesangium. So this is segmental. And since we only saw this in a few of the glomeruli, it's focal. So focal segmental glomerulosclerosis. So the two main findings in the glomeruli were FSGS, as well as some mesangial hypercellularity. The tubulointerstitium was relatively unremarkable, but we also saw something very interesting with the vasculature. So this is a trichrome stain, usually very useful for identifying fibrosis, which you would see in a dark blue color. But you'll notice this finding here. So adjacent is a relatively normal looking vessel. If you believe me, this was also a normal vessel at one point. So this red material in the middle is fibrin, and it has extended into the wall of the vessel. And there's also a bunch of karyorectic debris from neutrophils. So this is characteristic of a vasculitis. So moving on to the immunofluorescence studies. So for immunofluorescence, we use a variety of fluorescently labeled antibodies that bind to different immunoglobulins like IgG, IgA, IgM, as well as complement proteins like C3 and C1q, as well as kappa and lambda light chains. So I just included a few of these figures for you. There was these mesangial deposits of IgG as well as C1q throughout the glomeruli. And there's also some that's depositing along the tubular basement membranes. And I didn't show all of them, but we basically had strong staining for all of the immunoglobulins, all of the complement, as well as kappa and lambda light chains. And there's really one entity that has this quote unquote full house staining. That's kind of a buzzword for what we've been talking about today. So that's the findings for immunofluorescence. And then lastly, I have one electron microscopy image. I have a cartoon here just because they can be a little bit disorienting unless you look at them often. So again, we'll refer to this as we're looking at the EM image. So this here is the glomerular, or the basement membrane of a capillary loop, as well as an endothelial cell within it. So kind of like here in this image. This down here is the mesangium, so this area. And then out here is the Bowman space, so the podocytes. So normally the basement membrane as well as the mesangium is kind of all this light tan color or light gray color. But you'll notice that there's a lot of these dark deposits throughout the mesangium, as well as also found within the subepithelial space and the subendothelial space, kind of corresponding to the immune complex deposits that we saw by immunofluorescence. So these findings altogether are very consistent with lupus nephritis. I include this slide here not because we're going to go over everything, but just like lupus can present clinically so many different ways, the histopathology is also very complicated, and there's a whole bunch of different classification systems for trying to characterize it. But the findings from what we saw from our studies is that this is consistent with focal lupus nephritis, ISN-RPS class 3, with also some focal lupus vasculitis. We also included some additional information about different activity indexes that are used clinically. So, any questions? Thank you.
All right. Thank you so much, Kyle. All right. So you want to give the final diagnosis?
The lupus flare, and then she's got some obviously kidney disease. I think my last thoughts is, these things are really fun because it's really just about your process and how you sort of break things down. And I think that if I had to sort of retroactively think back to maybe something I could improve on, I think I did get really stuck on the infectious side because she was 18 and young and fevers and all this stuff. And we did have autoimmune in the back of our heads, but if you kind of look back on it, you sort of think, well, gosh, she's 18. Why would she have this overwhelming infection? It'd be pretty rare. She's immunocompetent. So maybe you start thinking that autoimmune should have been maybe a lot higher up on the list if you sort of break it down. But that's what makes these things really fun is that you get to do this without all the pressures of the wards and how do you get this lab and where's the culture and all the results are kind of there, so you can do it all in real time. So that was great.
Yeah, thank you so much. Excellent work. Maybe I'm dating myself, but if anyone has watched House, we finally got a case of lupus. She gets a lot better with steroids. Everything gets better with her clinical recovery. She started on hydroxychloroquine and MMF, losartan for the protein sparing effects, and she's DC'd on a pred taper. She's currently following with rheum and nephrology, and she just had an active flare again. So an additional med was started, Benlysta, which is a monoclonal antibody to block B lymphocyte stimulator, BLyS, which reduces harmful B cell activity, improves kidney function, and has been shown to reduce disease flares for lupus. For the sake of time, I'll just leave this up for your reading joy. But yes, it does matter to get the biopsy because it basically determines your treatment. All right. Thanks, everyone. Yeah, great job. Of course, you got it. Nice.
Well, it wasn't.